This is an I Am Listening exclusive podcast.
Yeah, and I just feel very lucky. I'm just blessed that I haven't had secondaries. I think that's the key. And my surgery's gone well, because if you've got secondaries to your other organs, it's a different ball game. Surgery is fantastic, but there is more to cancer.
Welcome to Dr Nicki Explains. I'm Dr Nicki, a GP of 24 years experience, and this is my friend Sarah.
I'm a mum of 4 with no medical background.
We've decided to do a podcast to explain medical conditions, hopefully in an accessible way. We often have a guest speaker who has experience or expertise.
The podcast is not a substitute for seeing your GP. If you have medical symptoms that are troubling you, please see a doctor.
We've based the podcasts on NICE guidelines, which is the National Institute for Clinical Excellence.
The podcasts do contain graphic descriptions of medical conditions and may not be suitable for a younger audience or those of a sensitive nature.
Thank you for listening. Morning, everybody.
Good morning.
Good morning, good morning.
So I'm Nikki, and today we've got Sarah.
Hello, good morning.
And I'm Ben.
And Ben, it's fair to say that you're a vet.
Yeah, so I'm a vet. I mean, I don't like to be labelled as a vet, but you find as you get older, you become what you are. So that's what it is now. I was originally a handsome young man. Now I'm just an old wizened vet.
Well,
equine vet, horse vet.
Well, here you are sitting on a sofa between two beautiful ladies.
Absolutely.
Yeah.
Just going to clean my glasses.
And today we're going to discuss rectal bleeding, and the reason for that is that we as GPs see it very commonly, but very occasionally it can be a sign of something more serious, and we just need to kind of work through what it could be.
And Ben's joined us because this is something that you've experienced recently, and you're going to chat to us more about that
a bit later on.
Yeah.
I think we're going to go through and just chat through the common causes of rectal bleeding first, because we don't want everybody out there to panic, because by far the majority of the rectal bleeding we see is not related to cancer. The kind of stats around rectal bleeding are between 1 in 5 and 1 in 10 people will come to GPs with rectal bleeding. And the commonest cause, what do you think the commonest cause is?
Piles.
It is.
I'd be guessing.
Piles. Those lovely vascular cushions.
Delightful.
That are around the anus. And often people, when they're presented with piles, will have other anal symptoms. So they'll say it's a bit irritating, it's a bit itchy. Sometimes it's painful, but really only if the hemorrhoid is what we call an external hemorrhoid. So what happens there is that there's a blood clot in it that then protrudes outwards, and you get a very painful external pile. People come in saying it's really hard to sit down, and really they do settle with time, but we tend to get people to sit on a rubber ring over some ice.
And of those 1 in 5 to 1 in 10 people that go to the GP with rectal bleeding, how many of them will end up just being piles, if that makes sense?
Yes, so probably a good 20 to 30%. There are some other, maybe even more than that actually. There are some other really common causes that we'll go through as well. I suppose it's probably more piles and hemorrhoids account for an awful lot of rectal bleeding.
But is there a gender bias in that?
Not really. I tend to see, because I'm a lady, more ladies come to me. So you have to be a bit careful about your own biased view of it. But no, I don't think
so. As a guy, you tend to think it's more of a girl thing.
Yeah, I mean, certainly we do see
piles.
Isn't it?
Yeah, that's
interesting.
It's linked to sort of straining.
Exactly. Post-childbirth.
Pregnancy, exactly. And if you do get piles in pregnancy, we would advise you to wait a few weeks after you've had your baby for it to settle down, because it can go on its own without need for intervention. What do? We obviously, you've got to avoid straining, so we give them laxatives. You can, if it goes on and on, have them little rubber bands put around them, and then they drop off. Bit uncomfortable for a few days when that happens, though. I think you feel like you need to go to the loo all the time while the rubber bands are on. You can have them injected. You can have infrared coagulation, diathermy, electrotherapy, but they're always really of just trying to shrink those little vascular areas and make them go away. You can have surgery. Surgery is where they take the whole area out. That is quite a big operation, and it doesn't sound it, but people that I've known, there's kind of infection risk. It's pretty painful afterwards for a while, and really, I would say, last resort itis.
So don't jump to that.
Don't jump to that. Try your laxatives first.
I'm assuming the majority of people are self-treated before they come to GP.
People have, but we have obviously got access to laxatives that aren't always available over the counter. So although there are some available over the counter, we could have a very quick chat about laxatives. So just so you know, because it is something I tend to talk to people about, we have mostly over the counter, we have stimulant laxatives like Senna. Senna propels hard stool. So if you have constipation and the poos are hard and you take Senna, you're going to get cramps. Whereas what we tend to recommend are osmotic laxatives. What they are, they're medication that draws water into the poo. So the next commonest thing, any ideas?
I would have said IBS, is it?
We are going to cover that. The IBS doesn't, so that's inflammatory bowel disease.
Yeah.
We are going to cover that. But
I think it's like tear.
it is.
Tearing.
It's anal fissures or tears. So what happens? Back to constipation. You have a hard poo and you strain, and then unfortunately, as it's coming out, it tears the anus and that bleeds. You tend to get sharp pain. Not always, though. When you talk to people, they don't always remember the pain of it, but it's usually a bit of a sharp pain and then some bleeding after an episode of passing a big hard poo. The thing about anal fissures is that any age can have it, from very young children up to older people. It is a condition that affects children as well. And there's often a history of constipation. And the commonest age, though, is between 15 to 40. And you can have acute anal fissures where you've been pregnant, you've got constipated once and it's happened, or some poor people, it doesn't heal up very well. Every time they open their bowel, it opens and bleeds. You sometimes get a bit of spasm around the anus. That's called a sentinel pile.
God.
So when you look, there's one little pile there, but it's basically where where the anus is kind of contracted around the cut.
So you're saying that you might be able to have, people might notice the bleeding, but not really be aware that it's actually a tear.
Exactly that. But there's usually nearly always a history of constipation before.
Okay.
So what do we do? Laxatives again, lots of fluids. Try not to pass a hard poo, because if you do, it'll open when it's trying to heal. And if it really doesn't heal up, you can use something called GTN ointment, or there's another one that you can use that you put on there, which basically what that does. Have you heard of GTN?
No.
It's GTN spray in angina. What it does is it opens up the vessels. It makes the vessels, we call it dilate, open the vessels up. So if you put that around the anus, it increases the healing because you've increased the blood supply to the area. So it works really well.
Does it therefore temporarily increase the bleeding as well?
Well, it's a good question because what it
From the vet.
does do is give you a stonking headache.
Oh.
However, because it's increasing, it's vasodilating everywhere, so it gives you a bit of a headache. But it doesn't, that effect wears off, weirdly. I don't know why, but so if you start to get a headache, it's worth another go because it probably will wear off. Yeah.
So these are all sort of, piles, anal fissures, they're similar but different in some ways, aren't they? They're
Exactly.
It's
that makes sense.
It does.
The common link here seems to be the problem of constipation.
Yeah.
There's another problem that constipation causes, and that's something called diverticulitis. Have you heard of that?
No.
Yeah.
Like the longest word in, all medicine.
Say it again,
Diverticulitis.
Okay.
When anything says itis, it means inflammation.
Right.
So
okay.
What this means is inflammation of the diverticula.
Right.
And what is a diverticula?
Yeah, no idea.
It's a little pocket or outpouching. So what happens is when you're constipated, the bowel squeezes along in sections. I'm doing a hand demonstration that nobody is going to be able to see. But basically, and I'm going to try and put it into words, one section of bowel squeezes, the next bit in front hasn't squeezed yet because the poo is in between the
that's
sections.
like classic peristalsis, which we all did at O level.
Yes. So first bit of bowel squeezes, then there's the poo, then there's a bit of bowel that hasn't squeezed yet.
Yeah.
Between those sections, if you're straining, then what happens is the bowel actually is forced outwards into little pockets.
Okay.
And they're called diverticuli.
I think of them as little balloons.
Little tiny little pouches.
Got it.
Yeah.
They're like little pockets.
Yeah.
Well, that can cause some problems.
Yeah.
It's commoner with age. It's commoner with genetics. So if you've got a family history, if you've got a low fibre diet, it's commoner. And lots of red meat, it's commoner. If you smoke or if you're obese, it's commoner. So if you're immunosuppressed, there's a high risk of complications from diverticulitis. So we have to be very careful with those patients. So 80% of people with diverticulitis are over 80 and only 5 to 10% are under 45. So it's commoner as you get older, really.
And how's it diagnosed?
So quite often, I think 90% of the time, you don't have any symptoms at all. So you don't know you've got it, and maybe you'll never know you've got it. So only 10% of the time do you get problems with it. But it can cause some bleeding. So sometimes we see people with anemia.
Yeah.
Sometimes you don't see the blood, you just get anemic and you don't know where it's come from. It can cause infections, and that's because the little pockets contract food and then they get infected. You can get abscesses. In that case, you're obviously very unwell. You get a mass, you get temperature, you don't feel very well. You can rarely perforate, so make a hole in it. That you're really unwell. It's like having appendicitis. You get peritonitis, it's called, and you have to have an operation to remove that section of bowel. You can have strictures. That's where it narrows. So you get a narrowing. Very occasionally you can get fistulas. That's where one bit of bowel joins to another bit of bowel. The two pockets linked together. You can get obstruction, which I've never seen, but there is a problem. And you can get sepsis, which is where you get an overwhelming infection. The commonest way it presents to me as a GP is with people coming in saying they've got pain, usually on the left side, and they don't feel very well. And then their bowels, usually they've altered. So they're usually regular, they've now constipated, or it's usually a bit of constipation that triggers it off, to be honest. So just to say, you can have diverticular disease without having a problem, but if they're infected and you're in pain, we tend to give antibiotics and fluid, and we do admit to hospital if you're very unwell, and we're really worried if you're immunosuppressed. So if you have medication that lowers your immune system, you're just more likely to get problems. So let's move on to something that young children get called intussusception. Intussusception?
Right.
Intussusception, another long word, but what it basically means is, when we were describing the little bit of bowel around the poo is contracting and the bit ahead of it is not contracting, so it's wider. What happens is the bit of bowel that's contracting sort of telescopes into the bowel in front of it. And the problem with that is it cuts off the blood supply to the bit that's stuck inside. So it's like bowel telescoping into the bowel in front.
Got it.
That makes any sense. I'm doing it with my hands again, and that doesn't help our listeners. But the problem with that is it cuts off the blood supply. So when do we get this? We get it when you're 3 months old to 12 months old, and the peak age is 9 months. So small children.
So it's as their bowels are developing and working out how to operate, and you are on a dietary shift from milk towards solids.
We're not entirely sure.
Common in horses at any age.
Oh, interesting. Yeah.
So intussusception is a common cause of surgical colic.
Yeah.
And that surgery is the answer, isn't it, normally?
Well, for children, we wonder whether there's sometimes there might be a gland that's inflamed that might have been the kind of ultimate sort of point at which the bowel starts telescoping. We wonder whether it's something like that, but I'm not sure what the evidence behind that is. But bleeding is a very late sign. So by the time if there's any blood, the child is very poorly. But it presents earlier than that with colicky abdominal pain, a bit like the horses. The child's usually pale, tired, quite floppy. And after 12 hours, they start vomiting. That's a really bad sign as well, because that means that they're beginning to obstruct, they're beginning to block, they're very swollen. So we obviously are going to try and pick that up very early. And you mentioned inflammatory bowel disease. This is another cause of blood. It isn't as common as the other things we've discussed, but it is relatively common, and it affects mostly young adults. And there's two.
This is what's commonly known as IBS.
Yeah. IBS. Well, you have to be careful you're not confusing that with irritable bowel syndrome. It's different.
I am confusing.
Yeah.
That's good. Yeah. Okay. Right.
So irritable bowel syndrome is mild. There's not a blood test abnormality. There's not a poo abnormality. There's not, if you operate on people, that you can't see anything. So, and it doesn't cause bleeding. So irritable bowel syndrome is, you get these sort of little rabbit pellet-like dropping like poos. Kind of poo can be diarrhea, sometimes called slightly hard, slightly loose. You kind of vary and you get a bit of pain and cramps. But there's nothing kind of to see, whereas inflammatory bowel disease is more serious. Do you know the two main causes of the two main names for the two different types?
No.
Inflammatory bowel disease? No. There's two. There's one called Crohn's disease.
And
there's one called ulcerative colitis.
Yes.
They are different. They're both when you look at the bowel under a microscope, there's inflammation in the bowel, and that makes it very red and sore and swollen. Sometimes it produces mucus, and it bleeds, and it's like very, very tender to touch. So you can imagine if you're passing a poo, that's going to make it bleed. So people present with blood and mucus in their poos. They are slightly different conditions pathologically, in that ulcerative colitis affects from the rectum backwards, and it affects the large bowel. So the large bowel is the bit nearest to the anus. And then you've got your small bowel, which is higher up and nearer to the stomach. And ulcerative colitis does not affect that bit of bowel, whereas Crohn's disease can affect anywhere from the mouth to the anus. So you might need dietitian support because people don't absorb very well their nutrients. And so sometimes we actually have to feed people with these conditions with feeds, which is horrible. And then so you can use, if you're not responding to biologicals, which we'll talk about, you can use surgery. And in Crohn's disease, the thing about ulcerative colitis is you can do surgery and remove all of it. But in Crohn's disease, you can't, because you obviously it
could be
not
to the bowel. Yeah,
exactly.
Yeah.
So you would only use surgery if there was a big stricture.
A localised area.
Exactly.
Of severity.
So I have got patients in whom they have had surgery for Crohn's, but biologicals have transformed this.
So tell us a little bit about biology.
So biologicals are...
That was in your gin.
If you're lucky. Biologicals are antibodies. So they're monoclonal antibodies. What are they?
Yeah, no.
So what they are is, in your body, antibodies recognise molecules on the surface of your cells. And so when you mount an immune response to a foreign bug or something, the antibody will recognise a surface molecule on the bug, and it will latch on.
There are more hand actions here.
There are more hand actions. I have to do the hand actions to explain it. And so...
To yourself.
Yeah.
Biologicals are where people have developed a specific antibody that targets a specific protein, and they're used really to combat the different illnesses that... so, for example, we use them in rheumatoid arthritis, we use them in all sorts of conditions.
Yeah.
And in ulcerative colitis, they're used...
So you use genetic engineering to make an antibody, and it's called monoclonal because they're all the same.
They're all the same.
Target certain things that go around in your bloodstream or in your tissues of your body, and inactivate them.
And do you do that in horses?
No.
Don't you? That's surprising.
So monoclonal, and that sort of therapy at the moment is not. They probably do it in small animal practice, where treatments for sort of blood disease and so on are far more advanced. But equine medicine is a little bit more basic. IBS, we would think of stress and lifestyle, and we think that we're all stressed.
Bowel syndrome, and inflammatory bowel syndrome. It's probably why I don't really call it IBS, inflammatory bowel disease, because I worry about the confusion.
Yes, absolutely.
And I say that because when I started having symptoms back only a few months ago, you always think, oh, I'm a bit stressed.
Yeah,
I got IBS, just ignore it. And that's the first thing you think about is the stress lifestyle. More than colon cancer.
That's interesting.
Yeah. Can you talk us through it? Because how did it start?
So as I said, I'm a bloke. I'm in my mid-50s, and I'm probably not the healthiest lifestyle person. Because I'm a drive around for about 4 hours a day. I spend a lot of time driving and snacking and those sort of things. And so I'm a bit prone to, going to, like a lot of blokes, going to loo quite regularly anyway, and what you are, what you eat. So in the summer, I just started thinking I'm going to loo a little bit more frequently, and maybe a little bit looser on occasion than normal. But it developed quite rapidly in September 23, and it's now February 24. I was not being able to control that. I was having to pull over in the car, find a bush, find a lay-by, and go into the loo very quickly. Lucky my car's very well equipped, so I can clean myself up quite quickly. And then it was quite obviously, quite rapidly, over just 2 or 3 weeks, that there was freshish blood in my poo. So I was quite lucky it was fresh.
Just about the looser bowels, because we have been taught now that with bowel cancer, it's an unremitting change to looser bowels. So did you find that, or did you find that you had loose bowels sometimes and okay bowels other times?
Certainly to start with, and when I say start with, probably with the most powerful tool in medicine is the retrospectoscope. Forget your CT, forget your MRIs. The retrospectoscope is king, and looking back, no, there were periods when I was fine, and that's why you thought, oh, perhaps it's just the stress.
Okay.
Because I was quite loose, and gas comes with the looseness, and so it gets a bit.
This was quite a short period of deterioration.
Yeah, so probably started just with the hindsight July time, but really didn't really think about it till August.
I see.
And then by September, it was becoming difficult. But then you'd have a good few days of being caught back to normalcy. You slightly ignored it again. And then you got blood streaks, and then you didn't. And that was again over really a relatively short period of time, about 3 weeks.
So you started seeing the blood streaks.
Yeah.
How long was it before you thought, I need to get some advice on this?
Again, because I'm a busy middle-aged bloke, slightly ignored it for a while. Did tell my wife, who started nagging me to do something about it.
Yeah.
And then early October, so again, 6 weeks in, I was actually just producing just blood for a while.
Did you have any mucus?
Yes.
Yeah.
Loss of mucus as well, blood and mucus. And then back to stools again, and then blood and mucus, and oh God, I better go and see my GP. And I had done a blood stool test because my wife made me the previous year, and that was negative.
That's called a Q-fit. Some people may have heard.
So you'd done that just as a
just because, a bit like blokes in the middle age. Oh, I better go and buy a PSA kit and stick my finger. Or people say you should do a home stool test. So I did a home stool test. I don't know which brand, independent of my GP. But this time,
and that's been absolutely fine.
That had been fine the year before.
Okay.
Yeah. So then, I was kicked up. Let's go to GP. It's quite hard for me to have to be on the phone for quite a while to get a GP appointment. So I didn't bother. And then a kit came in the post because I became part of a survey that's run by a local GP. I thought that's handy because I'm pooing blood all the time.
So this was just completely by chance?
Completely by random, the test arrived in the post, which was quite lucky. Well, we're not that lucky. I'd have rung the GP instead, but I might have delayed another week or two.
I was just going to say that there is screening, obviously, with the poo test for, it used to be 60 to 74-year-olds every 2 years, but they are extending that to 50. So Wiz was 55. We're part of a 55-year-old screen. The national screening program.
Yeah, that's exactly that.
Okay.
But it just happened to be coincidental.
That was good.
I knew I was in trouble.
Yes.
I think I was very lucky. I mean, I've been very lucky with my rectal cancer because it was rectal. It wasn't that far up. I've had to have 20 centimetres of my rectum up to my sigmoid removed.
So should we just, hold on, we've just gone forward a bit, haven't we?
So the point of that is because it's low down, the blood is fresh and really visible and easy to see.
Okay, right.
So, it was really obvious to me I've probably got a bit of a problem.
And the rectum is the commonest site for bowel cancer.
Oh, okay.
Okay. So you sent off this test.
Yeah.
And then what happened?
So 4 days later, they were on the phone. So, you need a colonoscopy.
Right.
So I booked one up.
So the word colonoscopy strikes fear into some of my patients' hearts. It's not a pleasant experience, but it's not the end of the world.
So, no. As the odd one out here, I haven't had a colonoscopy. What, can one of you explain exactly what happened?
I mean, so I booked a colonoscopy up, and that was just for me, it was 2 weeks later. And there are various things. The biggest thing about it is you have to take laxatives or up to 24 hours before, and stop eating 12 hours before, drink lots of water, and they're proper laxatives.
Right.
You have to drink a pint of quite sweetish jelly stuff down in one, and then you're on the loo for a good few hours afterwards.
Gosh, okay.
I do recommend the down in one because I think if you think about it,
you got it down in one.
Pretty hard to drink it. So just get on with that.
Okay.
And so you've got to be empty.
Yeah.
Before they could put a scope up your bottom, which is also quite uncomfortable. They give you options to have some drugs. Yeah. Basically a mild. Yes. So a mild opiate like a pethidine.
Opted for sedation, but it's
so did I.
And you did.
And they advise you. They often say you don't need it. My advice is I would.
I think you do as well. Yeah. It is a little bit uncomfortable, but the sedation drug actually does have an effect a little bit on your memory. So although you can remember it a bit, it's hazy.
And you can't drive home and stupid little things like that.
Yeah,
you have
drive.
drugs.
Just take someone that someone needs to come.
But it is uncomfortable. But the laxatives before was probably the main challenge, I would have said.
I would agree with that.
Right.
Yeah.
How long was the actual procedure?
Not very long.
You're then in the hospital for a couple of hours.
Right.
Yeah. And the actual procedure, about 15 minutes. Something like that.
Okay.
I can't remember because
No, I can't really remember either. But
I do remember seeing a pretty great cancer on the screen though, and there were lots of sharp intakes of breath, and you knew, even though I was drugged, what was going on.
I suppose as a vet, you're used to looking at
the
screen, you would...
But it's all nice and red and clear, and then it's black and bleeding. It's very,
I see.
Yes.
Okay. So you're conscious, you're looking at the screens there, you can see the scope going around.
You want to.
And they detected...
Can't see it going in though. I'm not quite good enough for that.
So
thank goodness.
You could see this cancer. I mean, what size is that? Can you speak to that?
Yeah. So I mean, for me, I've been bleeding out my bottom on and off for a few weeks. That was all. And then once they were 10 centimeters up my bottom, so not very far, suddenly going from just a bowel, which is like a red tube, pink tube. It's black, it's bleeding, it's obstructed. And in that, mine was almost completely becoming obstructive.
Right.
So
they couldn't really get past.
How common is bowel cancer, Sarah?
Yeah, well, in preparation for this, I was looking it up, and actually I was completely amazed to know that it's actually, one of the most common cancers. It's the fourth most common cancer. 42,000 new cases of bowel cancer are diagnosed each year on average. I also discovered it affects more men compared to women. So men, around 24,000 cases compared to women, 19,000 per year. And more older people, 43% of all new bowel cancers are diagnosed in people aged 75 and over, but obviously not restricted to that, as we're hearing. Good news is bowel cancer survival rates seem to have doubled in the last 50 years in the UK, and perhaps you can both talk to me about why that might be. And 54% of bowel cancer cases are preventable, it said. So I wasn't quite sure what that meant as well.
Natural history of the polyp. So the polyp is a sort of dongly thing that is the way a bowel cancer starts its life, and it goes through a series of genetic mutations to become more and more like cancer. So you can prevent bowel cancer altogether by removing polyps. So
if you have a colonoscopy, that's the most common thing you come across, isn't it? Polyp.
They're going to remove any polyps they find because they are all technically pre-cancers.
I see.
But they won't become cancer for 20 years, maybe 10 to 20 years. So you're preventing something that's going to happen a long way down the line. So if you have got polyps, sometimes polyps present with mucus. So if people come to me and say they've got mucus, I do think maybe there's a polyp and it's worth just getting that checked out. There are genetic conditions whereby people have a genetic tendency to make lots of polyps. There's one called Lynch syndrome and there's others. And these are inherited genetic abnormalities that people can have. And you'll get a family history. Dad had bowel cancer when he was 40. Uncle had bowel cancer when he was 50. My brother had it when he was 35. The younger the age, the more likely that there is a genetic link. And the younger and more relatives you have, the more likely as well. So in some people, we will screen for multiple polyps, and then we try and get rid of as many of them as we can.
But you mentioned familial history. Now, that's quite interesting because you ask that all the time. Because as soon as I've got a positive test, they ask you that all the time. No, I haven't got any familial history. No, I don't know what you're talking about. And then after my scope, my brother goes, oh, I've had some polyps removed. And my mother goes, oh, I've had some polyps removed. So I slightly, I not quite sure.
And they hadn't told
me. No.
I don't think it's something people are open about, which is why we're trying to do this podcast.
I think the point we can take from this is let's talk about polyps more, and let's not be embarrassed about it, because it sounds like a lot of people have them.
And if you're asked to have a colonoscopy, go for it. Don't be off, I think.
Yeah.
And if you've had polyps removed, tell your wider family, because it might be that can help them.
And in fact, there are various symptoms that we look for which are governed by NICE. NICE is the National Institute for Clinical Excellence that we base all our podcasts on. That they are the national guidelines. So I just thought I'd run through those.
So these are the symptoms. These are the other symptoms of bowel.
So abdominal mass is one. A change in bowel habit.
Abdominal mass. So sort of a large stomach. Yeah.
I mean, to be honest, people don't often come and say that they've got a lump in their tummy. It'd be very unusual. It's usually something we find when we examine people. They often notice that.
Yeah,
Beth,
they do.
Do you have any of that?
So no, but they do examine your bowel. So I basically bypassed the GP. I sent my test off, and then I got a call from the hospital. So I did for my colonoscope. But at some point in that process, you have your abdomen examined.
And as we've explained, the commonest bowel cancer is a rectal bowel cancer. So we would also just generally examine the rectum. So we would do a rectal exam, very gentle exam. And the reason for that is that most of the cancers are in the rectum. And the reason that they're mostly in the rectum is that is where the poo stays for the longest time in contact with the bowel wall. And we think that that's probably why that's the commonest place.
Presumably you're also ruling out those more common problems like piles and anal fissures.
Exactly. So you would expect to have that area examined. So abdominal mass, as you say, is not a common way of people presenting. A change in bowel habit, and as we've said, diarrhea is one. I was always taught persistent and unremitting change of bowel habit to frequent and loose stools, but what we've just heard is that it isn't always unremitting, and that you might have a bit of a variance, but it would be a change to your normal pattern.
And I think that sums it in a nutshell. Change of bowel habit could mean anything and everything, but if there's a change...
And it keeps going.
Yeah.
Don't ignore it.
Yeah.
You get a food poisoning, or you can get gastroenteritis, and you're going to get unwell for a week, but then it will go back to normal. But if it carries on going for no good reason, then that's a problem.
And you do sit there thinking, gosh, I had chilies last night, or, what have I eaten in the last few days? And it takes a couple of weeks before you start thinking, no, this is a change in bowel habit.
As we've discussed, rectal bleeding is a presentation of bowel cancer, and we think it's around 50% that present with rectal bleeding, but in combination with a change in bowel habit, and 20% present with just the change in bowel habit and no bleeding. 12% present with just persistent rectal bleeding and no bowel change and no anal symptoms usually. And 2%, so quite rare, present with abdominal pain provoked by eating that's causing weight loss. That's quite rare, but usually that tumour is higher up. So these might be people that have a tumour in the right side of their bowel. And we might find a rectal mass in 25% roughly of patients, an abdominal mass in about 12%. So it's relatively unusual, and 8% that might have a new iron deficiency anemia. So all those things might be indicators of cancer. There and again, if you have those symptoms, equally, as we've said, you may not have bowel cancer as well. So don't panic. Just get it checked out.
Weight loss. So I lost 3 kilos, which isn't a lot for me because I'm about 100 kilos. Last summer I thought, God, I'm doing really well here. I've turned the corner because I find it really hard to lose weight. But I think, again, with Rectal, that was because of the early cancer, the cancer started.
There's one other symptom I wonder whether you had, and it's called tenesmus. But what that means is that you open your bowels and they feel empty to begin with, but then 5 minutes later you feel like you need to go again.
Yeah.
So did you have that? Yeah.
Overwhelmingly, and still do.
Yeah, because the problem is there's something there, isn't there? And so it's going to stimulate you to feel that you need to go all the time.
I see the tumour is essentially triggering.
Yes. A, that, and B, and I think as it was towards it, it was becoming more obstructive, it was becoming a problem. My surgery was brought forward because it was becoming quite obstructive.
You went for a colonoscopy. Tell us what happened next. What happened next?
Yeah, so I had a colonoscopy, and because not because I'd seen it on the screen, but because everyone else had, I thought I had to stay behind, unlike everybody else who had a colonoscope that afternoon. And then I had a meeting, if you like. My partner was there, and the colonoscopist, the consultant, and 3 other members of the colorectal team from that particular hospital, and they said, you've got an invasive cancer. They gave me a written report there and then, which was the same report that went to my GP. And they said, we'll be in touch in a few days' time. And I then went the following week, within a few days, I went into the hospital, had a pre-surgery meeting with the consultant, with a surgeon. It was with a nurse, a leading nurse from the colorectal team. Went through all the things that you're going to need surgery, and you're going to need it. We set a date for a month ahead, and then the consultant came in and examined me, and we discussed it further. And the conclusion was that it was becoming quite obstructive, because my wife piped up that, in fact, my bowel habits were getting worse all the time and quite rapidly. I didn't say that, but she did.
Thank goodness. Were you told that you might need a stoma?
Oh, yeah. We can go into that. So
would you like to explain about?
So there was lots of things that came up in that. There was an hour-long consultation with the colorectal nurse. So one is no one knows what surgery you're going to have. You may have, if you're lucky, laparoscopic surgery, or you might have to be completely opened up. Keyhole surgery.
Yeah.
Or you might have to be completely opened up. They don't know how far they'll have to operate. They don't know how long the operation are going to be last. You might wake up with either two types of stomas. One is a colostomy bag type of stoma. Mm-hmm. The other one is an ileal stoma.
Explain what a stoma is.
So a stoma is a hole in your abdomen, in your tummy, either side. One would be on your left and one would be on your right, depending what type of hole you had in. And then you're attached to a bag, normally only temporarily, nearly in theory only temporarily.
The waist.
It bypasses where they've done the surgery.
Right.
So it was likely that I was going to have about 50% chance I was going to wake up with a colostomy bag because my tumour was in the rectum and they wouldn't be able to reattach to the rectum straight away. So they would divert your bowel to come out the side of your tummy and then you empty into a bag.
And it's fair to say that the chances of a stoma being more permanent are related to how low down the cancer is. So the lower down it is, the nearer it is to the exit, the more chance you are of having a stoma permanently because they can't reattach it.
I see.
But they'll do their very best to. But so what they would do is they basically take out that section of bowel that's got the cancer in it, and then you can't immediately join where you've cut the existing bowel off to the rectal stump. You can't bring that down, A, because it might not stretch, B, because it's all inflamed and swollen and sore. And so they bring that loop of bowel out that's been cut above the cancer to the surface, and you attach a bag and then you empty your bag with the waste in it. And then hopefully as things settle down, they can rejoin it, reconnect it. But if the operation's been very low down, that might not be possible. Right.
And reconnection they always seem to say, hopefully we'll be able to reconnect you, but that's months later.
Right.
Whereas the other stoma they were talking about is an ileal stoma, when they bypass the whole of the colon just for a week or so whilst it recovers from the surgery.
And the ileum is a part of the small bowel. So that, when we talked about the large bowel being the colon, and then above the colon, between the stomach and the colon, there's a section of small bowel, and that has got different names to it, but one of the sections of small bowel is called the ileum, and that's the bit that they bring out to the surface.
And so
before my surgery, which was... So I had the colonoscope on the 9th of November. I had my surgery on the 12th of December. The day I went in, I was marked up by a nurse as to where your bags would be.
Right.
And you didn't know whether you're going to wake up with one or not. So that's quite nerve-wracking.
Yeah. What actually happened?
So I was very lucky. I had a very good surgeon who I hadn't met. So the surgeon I had met pre-op wasn't the surgeon who did my surgery because he wasn't available that day. But I went in to surgery. I went in at 7 a.m, but they moved me to the afternoon list. So I didn't go into surgery till 4 p.m. You just lay there for hours while everybody else went. So that was a bit nerve-wracking. But I went down to theatre, and because it's your bowel, you sat on the edge of your operating theatre, and I had to have a spinal block. So because that helps with the post-op pain.
So spinal block is where they put a anaesthetic into your spine, a bit like it's not a lumbar puncture or an epidural. It's a bit like that.
Yeah.
But it's a dense nerve block.
Right.
So they put it.
So were you not under general?
No. So this is before the general anaesthetic, because it might not have been spinal, but they put painkillers, morphine type drugs, and so on into your CSF.
Right.
And when you come round, you won't be in so much pain.
I see.
So that was why it was. I don't know whether they would have put it in for motility reasons as well, but so you had that pre-op. So you sit on the edge of where you're going to have the operation. And your legs go numb, so then they have to maneuver your legs onto the table. I had to have an arterial line because in the pre-op assessment they'd found I had a mild arrhythmia, so I had to have an arterial line as well. So it's a few painful procedures and then a full general anaesthetic. And then so that was that. And 4 hours later, you come round and I didn't have any bags.
That was, the relief for that must have been nice.
Yeah. So that was great. Don't have your phone with you when you come round that evening because you start sending everybody WhatsApps and texts you really regret the following day. So, but
with great detail.
Yeah, exactly. So I went up to a surgical ward, and basically I stayed on the ward, and I just had normal painkillers of paracetamol and ibuprofen because you don't really want to have anything with codeine or anything in it because it causes constipation, which you don't want to have.
No.
And the point of being in hospital is just to make sure your bowels start working again and your urinary function, because the nerves that supply your colon and your rectum also supply your urinary tract and your sexual function, and they've been pulling on those nerves to get the cancer out. So they want to make sure that you're working before you leave. And that might just be producing gas, because you might not be working very well for a good few days afterwards. And I wasn't. I worked fine to start with. I left hospital and then I didn't go again for about 4 days. So I then had to start taking laxatives again. But that was all just sorted out over the phone. I didn't have to go back into hospital.
So you said you were warned about the possible damage to the function.
So I missed that. Back in that hour-long pre-op consultation with the colorectal nurse, she was pointed out the sexual function thing, saying what I just said is that the colon and the pelvic nerves are responsible for all the function of all the bits down there. So that's your bladder and your sexual function, and erectile dysfunction and not working properly in that department is a high risk of that, even with relatively simple surgery, high risk 10-20%. So she warned us about that, and they said don't ignore that post-op. If there is a problem, come and see it.
So that's hard hitting. Meeting.
Yeah, it made you think it was quite serious, and because you didn't know whether you're going to have bags. And then when you came round, you were quite relieved. And then the surgeon comes around the next day, and you speak to them, and he said, "Oh yeah, it was a bit tricky getting it out from around your seminiferous vesicles, which are part of your semen production." So you think, "Oh blimey, perhaps I am going to have a problem," and then you start worrying again. But you just you worry in stages as to where you get to, and then. And then it's quite painful. And although I had laparoscopic surgery, they lied, doctors as they do. It's not laparoscopic; it's what's called laparoscopically assisted. So you still got a scar the size of a C-section, as well as 3 holes where they put the scope through. So you've got a reasonably painful wound. And you have to sleep on your back for quite a few days. You can't sleep on your sides, and it takes a while to recover.
How long was your sort of recovery period? I mean, you're looking...
Yeah, so you had your stitches out. So I had stitches in my wounds, and they were taken out after 10 days. I was up around walking after about a week. I was relatively quick after that. I was back at work after 6 weeks. But just and my job's quite physical. I mean, I could start doing paperwork sooner, and it was all quite quick, really. Yeah. Probably not dissimilar to recovering from a C-section, but a bloke I wouldn't know what that was like.
Pretty grim. And how long ago was the operation?
So the surgery was 12th of December. It's now the end of February, and I was back at work by the 22nd of January.
Amazing.
But there's stupid things like, you shouldn't really fly for 6 weeks after you. So you think, well, I'll go away for a bit of recuperation. But because of gas build-up, gas is a big thing right now. So my colon I've had 9 inches of colon removed. They managed to do an end-to-end anastomosis. So I managed to, as Nicki said, attach the end of the colon to my rectum. But I think there's not that much rectum. They were quite chuffed with themselves that they managed to do that. And I have to be really careful what I eat now.
So tell me what what?
So interestingly, you know, because you have an unhealthy life, you know, we all know now about, you know, we're taught to eat more fibre, more fruit, more vegetables, less red meat. So that's the way that we're advised to do. But post-op is the complete opposite. You have, you know, you want it to be digested essentially in your upper bowel and your stomach and your upper small intestine. So meat is good, high protein is good, eggs and so on. Fibre, like even salad, is bad to start with, because that puts pressure on where you've had surgery and on your rectum. But gradually I've switched over a few weeks, painfully not painfully, but you know, experimentally, to a more healthy diet.
So for the people listening, what would be your key take-home messages?
So don't ignore blood in your poo is probably the obvious one. And funny enough, because I'm reasonably well connected, I've got lots of friends who are doctors. We went on a lads trip at the beginning of October, and I spoke to quite a few friends who are doctors, not gastrointestinal doctors, and they were all reassuring. So there's nothing wrong with you. You just got a bit of irritable bowel, or you know, stop worrying about it. So talking to your friends isn't necessarily the right thing to do, particularly if they're doctors.
Yeah.
But just act on what you see. As I said, I've talked about colonoscopy, and I think, you know, if the opportunity's there, you know, if you're the sort of person and you're in a privileged person where you perhaps go off for a Bupa examination and have an ECG on your heart, and you do your stress exams and do blood tests every now and then, you know, just think bowel as well. I think that's what I mean by that, is just think bowel as well as your other things. Chaps of my age all have their home PSA kits, but think bowel cancer as well as prostate.
Would you also add to that, perhaps be brave and ask members of your family about
family history? I think in our family is appalling. Yeah, it's really appalling. About
you're not alone on that, though.
I mean, I know my grandfather died of prostate cancer, but no one's ever told me that.
No.
And my other grandfather had a heart attack, and so is my father. But, you know, it's sort of not really talked about.
Have you had any help, sort of external help? I know there are a lot of charities out there to do with, you know, cancer. You mentioned that you've got a lot of friends who are medically based. I'm imagining.
I think if you don't, and firstly, the hospital are very good at informing your GP, even though I didn't go through my GP, just by luck, and did the home test that came through the post. They became involved as soon as they knew. And there's a lady from our GPs who deals with cancer patients, and she rang me up straight away. And I think I probably said I'm okay, because I haven't heard from her since.
Yeah.
And I also got a call from Macmillan, and that they feel, you know, mental health support, if you like, and worrying diagnosis. And I think possibly because I'm a scientist, I was less needing of that, and I have good family support. But it is offered to you. In terms of personal research, I found Bowel Cancer UK online to be the most useful and interesting. Their leaflet on post-op and dietary management moving forward is the best one I've seen.
Were there any other charities that...
Well, interestingly, when I had a look at those, Bowel Cancer UK was the first one on my list. So that's good to see. Cancer Research UK, Macmillan, and Guts fighting bowel cancer. That also looked...
I've heard of Guts. I mean, I think they're a little bit newer on the scene. I don't know.
Yeah.
Cancer Research UK seems to pop up in my Facebook a lot now.
Yeah.
Well, that's good to have those contacts.
Those gut feeling has never been...
Yeah, there you go.
So, I mean, important, isn't it? I mean, a massive thank you to you.
Thank you.
You know, when we were talking about bringing this up, when Nicki told me it was, you know, the fourth most common cancer, we wondered, you know, who would come and chat to us about this. You're terrifically brave to do that and being incredibly honest. And I think, you know, very, very informative.
I think it will be really helpful for people listening to have understood all the journey.
Yeah, and I just feel very lucky. You know, I'm just blessed that I haven't had secondaries. I think that's the key. And my surgery's gone well, because if you've got secondaries or other organs, it's a different ball game. You know, surgery is fantastic, but there is more to cancer.
Yeah, thanks very much, Ben. Brilliant.
Thank you.
We hope you've enjoyed this month's podcast. Don't forget that if this has made you aware of troubling medical symptoms, you may need to see your GP.
This has been an I Am Listening exclusive podcast. For more information, head over to our website, iam-listening.co.uk.